Who performs a comprehensive geriatric assessment? An older adult care needs can be complex and unique. The comprehensive geriatric assessment process requires a coordination to ensure the experience is positive for both the patient and their caregiver or family, and also for the provider. So a very positive relationship between the provider and the patient and their family. Any member of the interprofessional healthcare team can coordinate a comprehensive geriatric assessment. Individuals, the patient, and their family trust to maintain a climate of mutual respect with open, caring interactions. It could include geriatricians, which could be MDs or DOs, psychiatrists, psychologists, as I said before, PAs, nurse practitioners, RNs, pharmacists, social worker, OT, PT, on and on. Okay. The benefits of a comprehensive geriatric assessment. It reduces mortality, improves independence, so the resident or the community resident ages in place and maintains their independence, reduces emergency hospital admissions versus the individuals receiving usual health care, the usual healthcare format that we have in place currently, improves diagnostic accuracy, decreases in-hospital care treatment complications, and facilitates effective discharge planning and less readmission, decreased admission rate. In the community setting, a comprehensive geriatric assessment reduces hospital admission, so it keeps the resident again in place, aging in place in their home and independent, decreases the risk for actual readmission of recently discharged older adults. If they don't have the supportive care once they leave the hospital, their risk of being readmitted right away increases. Optimizes rehabilitation treatments to maintain mobility and enhances health and functional outcomes. The next of our 4 M's, of the 4 M's, is what matters. Again, what matters to the patient, what matters to their caregiver, what matters to the family. And this includes culture and diversity. So here at SUNY Downstate, we have a very rich, diverse community surrounding us. And so, of course, our patient population or our community residents reflect that. So rich diversity of persons, cultures, languages, races. So we need to take that as providers into consideration and respect that as much as we can, while keeping the healthcare goals in mind and keeping the plan of care in mind. So ethnogeriatrics is the influence of ethnicity and culture on the health and well-being of older adults. Ethno-Gerontology is the study of aging in reference to race, national origin, and cultural practices. An individual's health is influenced by culture, language, national origin, religion, education or lack of education, income, assets, and level of acculturation. How well have they assimilated into the United States population? How well have they adapted to being in the United States versus being in their country? How much of their original culture and beliefs do they still hold on to? How do they practice as far as it relates to healthcare? Addressing these issues for the older adult immigrant requires policymakers and healthcare providers, us, to be familiar with patients' health beliefs, risk of disease, family systems and structure, access to care, and dependency on adult children. The number of foreign-born adults is increasing. So therefore, some regions of the United States, immigrants comprise a significant portion of the older adult population. So if the overall population is aging, of course, the immigrant population is also aging. The traditional comprehensive geriatric assessment provides valuable information essential to caring for older adults. However, it often falls short in multicultural immigration, for the multicultural immigration population. We, as providers, healthcare providers, must be sensitive to the limitations of our current assessment tools. So the assessment tools that I mentioned before, some of them are not friendly to our immigrant population, and I'll cover that in a little bit. Consider the limitations to cognitive screening tests, delirium assessments, functional and mental assessments, advanced care planning, and elder abuse assessment. So some of our instruments do not take that into consideration and therefore have limitations. Undocumented older immigrants face additional challenges beyond serious chronic illnesses and issues. Often they have poor or no access to health care. They usually present with more advanced health problems because they don't have access to health care, and sometimes they do not have the finances to pay for regular preventive medicine or regular preventive visits. Require more costly treatments because it's more advanced when it is identified, and interventions have lower cure rates. So as the disease progresses or disease is more advanced as it's identified, the cure rates are lower because it may be beyond really treating it and eradicating it. It may not be able to be treated at all. Do not receive primary preventive care because they can't afford it, or also because they're not used to having that. So they're here now, and we need to educate them that this is a requirement, because a lot of persons do not think they should go for a physical or a healthcare checkup unless they have a problem. So it will be a problem-focused visit. Preventive health is not something that they're used to having done or they could afford to have done, which results in increased healthcare costs when they present with an illness or a complaint. They are at increased risk for elder abuse just because of the stress in the family, again, the psychosocial stressors at home or what may be happening in their home or who they're living with. And immigration status and fear of deportation is a vulnerability they may be that may be exploited. So they're persons in the community, in their neighborhoods, who, because they're immigrants, will tell them that if they don't do something, they don't pay so much, then they will be reported or they'll be deported, and so they're at risk of being abused that way. Ethnogeriatric topics necessary to optimally care for an older adult immigrant are not typically included in a comprehensive geriatric assessment. So this current format of the comprehensive geriatric assessment that we have or just discussed. Usual comprehensive geriatric assessment tools have not been validated on multicultural immigrant older adults. Completion rates of preventive health care, such as vaccines and cancer screening, is low in the older adult immigrant population. And sometimes it's actually low in the American population also, of citizen population, depending on their health literacy, their access to care, and their healthcare diversity, how much they're able to get access care where they live and be part of the preventive health and wellness screenings. Language barriers are issues for a medical visit in any group, but just think even more of an issue in patients that are from immigrant populations. The geriatric assessment should identify documents that the preferred patient, in the preferred patient population language, and strategies to address communication barriers. Another thing that's to be aware of is we do provide, I know Downstate does provide interpretation of patient education materials. We provide a Siricom translator, but there are dialects that do not translate. We aren't able to translate, and some persons from the immigrant population, older adult immigrant population, may not be able to read their primary language. So even if they're, say, Spanish speaking, and the medication label or our instructions are in Spanish, they may not be able to read Spanish. They speak it, they cannot write it or read it. So something to be aware of. So which other section of the Comprehensive Geriatric Assessment do you think requires updates to remove barriers to optimal care of older adult immigrants? And that is the end of my presentation. Thank you so much. I hope this was informative. Thank you.